Hi everyone, welcome to our rettsyndrome.org RettEd webcast today. If you joined us to hear about what's going right in their brain, maximizing neuroplasticity in therapies with Dr. Pam Diener, you have arrived at the right place. This is Paige Nuez, Director of Family Empowerment at rettsyndrome.org, and on behalf of all of us at rettsyndrome.org, our board of directors, we want to personally thank you for being with us today. Your support and engagement, continuous awareness and empowerment is even more important during these uncertain times. And I say this as both a parent to a beautiful teenager with Rett syndrome and as your advocate at rettsyndrome.org. We want you to be as educated and empowered as possible to care for your child. And as you speak to others about Rett syndrome, you can count on us to keep bringing you the latest news and information and to continue pushing for new and innovative ideas. We have a lot of information on our website right now about things to do at home specific to the pandemic and COVID. Dr. Pam Diener was booked with us a number of months ago to come with us today and talk about her work in the field of neuroplasticity and with Rett syndrome. But based on the questions that were submitted, she's modified her presentation to be more relevant today. So in the interest of time, I know she has a lot of great information to share with us, and we have a lot of questions that folks have submitted. So Pam, if you'd like to go ahead and introduce yourself, I'm going to turn the screen over to you.
Okay.
There we go, and we'll get your slides up on the screen.
Okay.
Yeah, just take a minute.
Okay, so hi everyone. Thank you for attending today. I hope that this presentation helps you with some of the things that you are wondering about and considering at the moment with your child, your student, whoever you may be, however you may be related to someone with Rett syndrome. My relationship with Rett syndrome is long. I have a younger sister who has Rett syndrome, and I am also an occupational therapist working in pediatrics. So I've treated multiple neurologic disorders as well as children with Rett syndrome. And as a developmental neuroscientist, I have worked in the area of Rett syndrome, both in the clinical and the animal or preclinical models for many, many years. And so I'm sharing today some of the information that I think may be helpful to you all about maximizing neuroplasticity in therapies. So I'm going to get started with that right now.
Okay, and Pam, while you're going into full screen mode, I just want to remind everyone that today's session will be recorded. So if you can't stay online for the entire thing, don't worry about it. You'll get a link to the recording. And as Dr. Diener is going through her material, if you have any questions for her, there is a question box. And you can type in your questions and we'll address those at the end of her presentation. Okay, there we go. We're in full screen. Okay.
Great. All right, so the one thing I want to say before I begin is just that some of the research that I will be presenting is research that is not yet published. I wrote on those slides that it's confidential, but really all of the research that's presented is confidential until it's out in a publication. You can find it in a paper. So please do not take any screenshots or in any other way show this information to others. You can rewatch it on the Rett syndrome website, but please don't share it elsewhere. Thank you. Okay. So the focus of today's talk is going to be divided up into sort of 3 chunks. And I did that, and as an OT, I'm very very much color coding of things. And so that's how I chose to do this for you guys to help keep you also focused on the different topics. The first topic that we're going to talk about is to look at the motor-related deficits in Rett syndrome. As we all know what Rett syndrome is, I just really wanted to focus on one area. And I'm going to discuss some of the brain regions, both the layout and what the responsibilities of those brain regions are for typical movement patterns. In the second chunk of the talk, I'm going to try to give you a better understanding of how movement can be achieved, what the general concepts are that we can apply in order to help us encourage our children or siblings or students to move. And I wanted to talk a little bit about the difference between feed forward and feedback concepts for motor control, because I think if you understand those, you may have a better sense of how to take the everyday information, items that are in your home, and then be able to figure out how to use them with your child and therefore be able to encourage movement. In the third chunk of the talk, I'm going to focus more on ideas behind how we can encourage the movement through enrichment. And I hope to have you come away with a greater understanding of the need for multisensory experiences and how that actually affects neuroplasticity in the brain, in other words, brain connections or synaptogenesis. So I'm going to start with just thinking about Rett syndrome, and we know all the details of how it stages, et cetera. But when we talk about movement, what we're really focusing on as an occupational therapist in particular is the loss of purposeful hand use. And we're also considering the loss of speech and the ability for communication to let us know what they want to do, what they desire to reach out for. There's also a loss of gross motor skills, whether it be postural control for walking or sitting postures or just simply moving the limbs. We also look at the fact that there is some diminished sensation, and the children tend not to, or the individuals with Rett syndrome tend not to process sensory information in a typical way. And so we have to consider the delays or the changes in processing that also occur in Rett syndrome. And this all work together leads to or involves the idea that there is difficulty with initiating and planning of movement. And so we hear the terms dyspraxia and apraxia, difficulty with motor planning and unable to motor plan. And if we know that those are the behaviors, we then really try to figure out, well, what is underlying that? What is the nervous system doing or not doing to cause these behaviors to be apparent? And if we start off with looking at the initial near normal development and normal head circumference at birth, that suggests to us that initially, at least, the brain may be doing all the things that it's supposed to be doing. The brain is growing and the head is growing with it. But then we start to see that there's a delay or a decrease in this head growth that starts after birth, somewhere between the ages of 5 months to 4 years. And because there's a decrease in head growth, it suggests that the brain isn't doing all that it's supposed to be doing. It may not be creating the connections that it should be creating in order for it to be expanding and growing throughout the early years of life. We also see that there's a loss of purposeful hand use that happens somewhere in the time frame of 6 to 30 months after birth. And that suggests that maybe there's a withdrawal of connections that were already present, or a failure of messages to actually get to their target so that you will get a purposeful action or purposeful movement. And that's all part of this idea of difficulty with planning motions or dyspraxia. We also see the stereotyped hand movements, and that's might be suggestive of the need for stimulation, is one idea, and there are multiple others, but that's the one I want to focus on for this particular talk. And then the last bullet talks about gait and truncal apraxia and ataxia that happens between 1 and 4 years of age, and this seems to be something that we may be able to correlate a little bit with proprioception, or knowing where our body is in space. And the microscopic issues that we see in Rett syndrome can really help to expand those thought processes, so that if we understand that we may be losing head circumference and therefore losing connections between the brain cells, we might suspect then that that might be due to the fact that there's misregulated levels of BDNF in the nervous system in Rett syndrome. And with that, we're going to see potentially changes in survival of neurons and changes in synaptogenesis, or the connections of the neurons. We also may excuse me, we also know that we see decreasing numbers of branches coming out of the brain cells, so that the number of connections that can be made are decreased, not only because connections aren't made, but because there's less ability of the nerve cell to find other targets because it has less branches. Kind of like thinking about a tree that's just a trunk and doesn't have the branches to create all the leaves. If you don't have the way to access something, then you're going to not be able to function. And so the studies that we have looked at, that we're going to look at, today, are studies that are focusing more along how enrichment can affect the misregulation of the BDNF levels and how it can affect the branching patterns of nerve cells. And then with that, we can look at how that underlies the changes that we see in behavior. And so the question really comes into play is, can we use the concepts that we gain from the enriching studies every day in our lives in order to improve the control of individuals with Rett syndrome? And I think that before we can really delve into that question, we need to make sure everybody understands what the brain is all about. So I have a picture, multicolored picture of the brain to try to divide it up into its different parts. There's the front part that's red, that's called the frontal lobe. The yellow part is called the parietal lobe. Blue, occipital, purple, temporal, and the brown structure in the back is the cerebellum. And the little area that's sticking off at the bottom is called the brainstem and the spinal cord. And it's absolutely imperative that all of these areas function together in order to get normal or typical movement patterns. And so the foundational thoughts that we need to keep in mind when we're considering this major integration of all brain parts is that sensory input needs to guide the motor output. That no sensory function will typically work in isolation. They all need to be integrated. And we have to consider the ideas of feed forward, which is forward planning of movement, and feedback, which is the reactions when something occurs, and how those two systems, feed forward and feedback, assist us to refine our movement patterns. So if we go through the brain and think again about this entire brain, it has a cortical area, it's called on the outside, and it has structures that are located deeper inside, and they all need to speak to each other. And they need to speak to each other in a way that's very uniform so that the sequence of the conversation, so to speak, in the brain is logical, and so that the movement patterns that come out organized, sequenced, and coordinated. And so to do this, let's think about all the different parts of the brain. The corpus callosum is the part that connects the right side of the brain with the left side of the brain. And it does that throughout the entire extent of the front to the back of the brain. You have lots of connections. We also, I told you, have a sensory cortex that's present on both the right and the left side of the brain. And the sensory cortex is important for understanding and interpreting, receiving and interpreting our touch sensations, where our body is in space, any pain that we might be feeling, hot, cold temperature changes, and just in generally interpreting where is that sensation on our body, how long is it staying there, and and the other aspect of it is where am I in relationship to those objects, to the wind that's blowing on me, to the maybe piece of cloth that I just brushed past. We then move to the motor cortex, which is the red area, and the motor cortex and what's called the prefrontal regions, the part that's in the front, are going to be involved first in motor planning for the motor cortex, and then for controlling our executive functions, concentration, judgment, decision-making, those sorts of behaviors would be all found in this red region. Deep to all of that, we're going to find some structures that are located inside that have to do with emotion, learning, memory, helping us to refine our movement patterns so that we get the just right motion and the just right force, and we eliminate all competing motions. And another structure that's called the thalamus, that is our real connection between all of the things that happen in our sensory regions of the cortex and all of the things that happen in the motor areas. And it integrates everything for us and communicates with all regions. Finally, we've got the cerebellum that I told you was in brown before, and the cerebellum is involved in coordination, in equilibrium, balance, and postural control. The purple area and the blue area represent some of our special senses, our sense of listening to something and interpreting what we heard. Was it music? Was it conversation? Was it a bird singing? And the visual cortex is involved in receiving information about our visual world and interpreting that, and then allowing this area to converse with other regions of the cortex in order for us to get more information about where that object is in space, what is that object, and therefore we can then coordinate all regions of the brain and the brain stem. The brain stem and spinal cord as the final areas really are the final regions where pathways from the body and pathways from the brain will pass in order to get to the muscles. So the nerve cells that control how the muscles of our face move are in the brain stem, and the nerve cells that control how the body moves are in the spinal cord. So all the integration that occurs up in the brain needs to pass through these two areas in order to direct or guide motor control of our face muscles and motor control of our arms and our legs and our center trunk. And then the information that comes in from the body, from our skin, from maybe our tongue, from our face, that information all needs to rise up into the cortex in order to provide information to the brain and to the cerebellum about where our body is in space and what's going on with our sensations. So if we focus now on the purpose of the brain regions involved in movement, I'm going to more specifically identify that the sensory cortex is going to help us know where the body and the head is in space. That's this region. It's going to interpret touch in the yellow area, auditory information in the purple, in the blue area, visual, and taste and smell will be carried out in multiple areas throughout the brainstem and in the brain. And in addition, when we see something, smell something, hear something, it motivates us to either go closer to that object or move away from that object. And that's all going to be perceived in these sensory regions of the cortex. The frontal areas of the red structure and all of the deeper structures are going to be more involved in our motor control. They're going to initiate movement, plan and execute the movement, and provide the emotional content that we often have that creates movement, such as, and my example is, if we raise our arms up to cheer that somebody scored a goal, that's a very common response. And it's a motor response, but it's guided by an emotional content. The cerebellum and the brainstem are going to help us with the integration of our movement patterns to make them coordinated and allow for just right movements to occur. And the spinal cord will help with both sensory information and the final control of our muscles. So again, if we clump these together, you can see that there's this great integration between all parts of the brain. And if we only stimulate one region, you may only get part of a response. And what we really need is to make sure that we integrate all of these areas to get a global activation of the cortex, a global activation of the cerebellum, brainstem, and spinal cord in order for them all to work together to create fluid motion. And in addition to that, we also have to consider the fact that the left side of the brain and the right side of the brain work differently from each other. The left side of the brain is more of our logical side, the factual side. The right side of the brain tends to be more of the creativity side, the side that allows us to listen to music, to understand and perform well in art, to have intuition, and focus on that as opposed to focusing on the logic and the facts. And to think about the tone of a voice the melody when we speak, if a person has an accent or not, that all is controlled on the right side of the brain. And when you think about the left and the right side, think about the individual with Rett syndrome. Our left and right brain are not mirror images of each other, even though they have the same lobes that I just described to you, the red, yellow, purple, etc. areas. They're different, and we need to tap into both of those differences. And the fun part about the corpus callosum that I described that connects both sides is it will help to connect the creative side with our logic and factual side. It will help to integrate all of this so we consider both sides when we're making decisions. But now consider the individual with Rett syndrome. Which side do you think your particular child may have a more active side? So is their right brain with the music? Do you think that that's maybe the side that you really can stimulate and motivate them with? Or is it the math, the reasoning, the logic side? And that's an individual decision, as every individual with Rett syndrome is unique. And so just think about that in your particular situation. The other focus that I want you to think about is, do you ever see your child start to fall asleep? Does your child always remain active when they're watching a television program or they're involved in their homework for school? And if you start to see that there are some times when they are using or focusing on the left brain activities, that they begin to fall asleep, it may be that things like music may be able to alert their system, awaken the right brain again. While the left brain is working very hard, the right brain may start to shut down. So awaken it by just giving instrumental music. And that may, because of the corpus callosum connection, this connection between the two hemispheres, it may allow the activation of the right brain to keep the left brain focusing. And the focusing that's going on in the left brain may be able to, the connections that are occurring to create the learning may be able to occur in better for that particular task that's being done. So here's where I want to shift from thinking about the brain structures, giving you that really quick overview. And I want to focus now on the actual movement. So we know that the brain requires integration to move, but let's look at what kinds of movements we can have. We start off initially when all babies are born with reflexive movements, and those reflexive movements can be seen, some of them throughout life, some of them get integrated. But for an example, for you all to recognize and be familiar with, is if you touch a hot pot, you pull your hand away, that's a reflex. If a physician taps on a tendon and the arm moves or the leg moves, that's another reflex. If we step on an object that is painful and we need to pick our foot up off that object and put the other foot back down on the ground, that's another reflex. We can also take a baby lying down on a surface, and we can tickle or irritate the bottom of the foot and cause the baby to withdraw or move that foot back. And we can take a baby or a child or an adult, and we can move them forward, whether it's over a therapy ball, or if they're small enough, we can move them forward with just our hands holding them. And you'll see that they'll thrust their hands out, their arms out, and try to reach for a surface. And that's a protective response. All of these are reflexive responses that occur automatically. And we can use these in therapy to try to stimulate movement when voluntary movement is not occurring. Another type of movement that we have is the learned automatic response that I mentioned to you before, raising your arms as an example for emotion. So to cheer on a team as an example. We also have rhythmic movements, and rhythmic movements we see as we are beginning to develop, and some of the early reflexive patterns that we see in an infant begin to become integrated so that we can stop moving our body as a whole and start moving our body parts individually. And we see that as the child begins to sit and crawl and finally move up to standing, eventually walking, And as they get older, we can modify the walking skill, the walking pattern into running, climbing over obstacles, running upstairs, whatever it may be. And we can navigate other types of environments like the resistance that water provides. And we can change the way our normal rhythmic pattern would look so that we can move ourselves through water, sand, whatever it may be that we're walking on that's not a typical flat surface. So the other kind of movement that we have that isn't so reflexive or pattern generated as the motions I just described are, the other type is called goal-directed movements. And that relates more to this non-purposeful use of the arms that we see in Rett syndrome. Goal-directed movements usually involve reaching, and with that reach, you can see that the hand may be patterned in a particular way to get the object. So you can tell that this hand that's reaching looks different in terms of what it may be grabbing than this arm or this one. And you can almost imagine different objects that this person may be reaching out for based on the pattern of their hand. The grasping that is associated with the reach is goal-directed. Usually, as I said, you're reaching for something. The upper diagram shows reaching for nothing, but here you see a child reaching for cereal or marbles or something that's there that you place on a tray for them to pick up. And goal-directed movements don't have to just be reaching and grasping. They can also be modifying that pattern-generated motion of crawling, walking, by putting the person into a situation where they have to step precisely onto something like these stepping stones. And if they don't, they'll slip. And the way in which you step, each step is going to look different than the next, depending on how far apart the stones may be, rungs of a ladder climbing up, whether you skip a rung or do every rung at a time, it will look different. And those are precise patterns that are goal-directed. And that's a little bit different than just simply walking over ground. When we think about goal-directed movements, we think about more our fine motor skills, though, than gross. We're not thinking about great big trunk movements as much as we're thinking about more precise placement of a foot or placement of the hand. We're also thinking about our self-help skills, whether it be bathing, eating, or dressing. When we focus on all of these movement types, so from reflexes all the way up to goal-directed motions, we see that there's sort of a pattern that develops. An early reflex may be a movement pattern that becomes stored like a file on a computer. It becomes stored inside of our brain, and then we call up that pattern and add to it and coordinate it with other patterns in order to create the goal-directed movement. So it's essential that the child goes through these reflexes at early stages and develops these movement patterns. That's essential for normal movement. If they don't develop these particular movement patterns and they don't get stored for us to then take those different chunks and put them all together to create a solid fluid motion, as therapists, we need to help them develop some of those movements. And that's part of what therapy is about. And it's important so that they can then learn how to navigate their environment by sequencing movement patterns. So again, the goal that we have is to restore and train. After we restore movement or we develop movement, we train the goal-directed movements so that we can use all of these reflexive and automatic responses in order to create a better awareness of where our body is in space and how it should be moving with respect to the task that we want to complete. So here's an example of how we could do that. If you have a person who is not engaging in reaching or bending their elbow to come forward to grab something that you're holding out for them, in therapy, one of the things that we do is we can increase the weight, a sudden weight on the arm that makes the arm drop down and then pull back up. And it's what that's doing is it's a quick stretch. It's like the physician when they hits the tendon with a reflex hammer and you get a quick stretch. a heavy book, as shown in this particular example, can cause the arm to drop down, which stretches the tendon of the muscle that bends your arm back up. And so we can use that idea, that concept in therapy in order to work on bending the arms to try to get a person to reach for and whatever object it is that you are presenting to them. And the idea behind that is we are trying to tap into a spinal cord system that's already in place. Sensory input coming in, motor output going out. That's one of those essential foundational ideas that I suggested in the beginning. And then we want to, through training, work on allowing the cortex to begin to guide some of those motions so they don't happen all the time. That pattern of motion of, say, bending the elbow only happens when you want it to for a particular task. So while we're learning our movements, patterns, how do we know that we're moving in the right direction? And the way that we know that is through motor control, or this feed forward and feedback idea that I told you I was going to mention. So let me first talk to you about what motor control is like. If we want to reach for an item, a goal-directed action, I want to get this cookie. The first thing that I do is I look at it, I see the cookie, and I have this desire to reach. Those are already two different brain areas that we're interconnecting. Then I have my plan in my motor cortex to extend my arm to reach out and grab that cookie. Well, the initial reach, the initial initiation is pretty quick. We speed up that motion, and when we get to the top of the curve, as you can see here, the motion slows down. Well, how does that correlate? Here, you can see the arm is reaching out, and as it's getting closer to the target, the speed at which it's reaching slows down so that it approaches the target with a slower speed and it's more coordinated. The same thing happens once we grasp that cookie and we bring it back to ourselves. The initial grasp and pull back towards our face is going to be quicker, and then it slows down as we begin to bring the fork, if we had a fork that was loaded, a spoon that was loaded, or in this case, the cookie, to our mouth, so that it doesn't just crush and go flying into our mouth. So the idea behind normal goal-directed movement is we need to see what you want to reach for. You want to reach out for it. The reach has to be initiated. It's initially quick, and then it slows down. You get your object of interest, and then you bring it back to your body again quickly. And then once you reach the target of wherever you wanted to put that object, washcloth on your arm, food into your mouth, we should be slowing down as we approach that final stage. The difficulty that we see in Rett syndrome is that initiation part can often be delayed. And people question, how is it that we can improve initiation, or how is it that we can improve reaching and separation of hands? And part of it is we have to give the child something motivating, or the individual with Rett syndrome something motivating, but we also have to give them the time to begin the task. So if you ask them to start a task, you need to give them up to a 10-second time period to try to do the task before you ask them to do it again. It would be like somebody constantly hounding you and saying, give me, give me, give me, give me. They need time to process it. And the more you say, give me, the more confusing things can become, and they might shut down. So what promotes initiation of movement? Well, I can give you a neuroanatomical reason. It's the role of multiple brain regions working together, and we've looked at that. But an environmental reason is that internal or external motivating factor. Internal, are you hungry? Are you sad? What's going on? External is you see something that you would like to have. You hear something that you would like to have. And research is helping us to understand that this motivating aspect of initiating movement is extremely essential. And that's going to be most of what the third part of my talk is going to be talking about. I want to first get back and finish this goal-directed skilled movement idea. Is how do we know that we approach the target? So I told you that how the movement works, but now we have to throw the rest of the nervous system in. We need to know how we know we're approaching the target. Well, visually, we see that we're approaching the target. If there's a sound that the target makes, we may also know auditorily that we've approached the target. And we know where our body is in space, which is called proprioceptive input. Which is called proprioceptive input. All of this is processed in the brain and the cerebellum, and it helps us to get these precise body motions that we need to make because we have a precise map of where our body is in space inside of our brain. So the other piece that we need is to think about, if we have this information coming in and we know that we have to do certain things to reach and initiate and be motivated, etc. Well, how is it that all of that occurs in a very coordinated fashion? Well, part of it is because our body makes adjustments for our movements. Some of those adjustments are made ahead of the movement, and some of those adjustments are made in response to the movement. So what I mean by that is feed-forward mechanisms tend to allow us to prepare our body, our postural skills, as an example, prepare our body to move. And it seems like when we're moving towards larger targets, we rely more on the feed-forward mechanisms. Feedback mechanisms, in contrast, are, for example, you're reaching for something, but you bump into something along the way. And when you bump into something along the way, you have to make an adjustment. Well, how did you know you bumped into something? That's because of the feedback that came in from the sensory information on your skin or to your muscles. And we believe that the feedback information is going to be more important for us when we're working on trying to reach for or grasp smaller targets. So if we focus on the idea of feed forward first, let's go back to those pictures that I showed you where people had 3 arms reaching and they weren't reaching for anything, but you saw the shape of the hands. And the hand patterns were different. And the reason why the hand patterns were different is because they were reaching for different size, shape, and shape objects. And so you saw that was a preparatory action. They were ready to pick up an object that was either big or small or round or cylindrical. As opposed to feedback, if you think about the baby picking up the little pieces of food on the tray, they may not, you go to pick it up and maybe that piece slides across the tray a little bit and you have to adjust your motion. Well, that's feedback information, not feed forward. The feed forward was your fingers were ready to grasp, and the feedback was it didn't work, and now how do I have to change it? And some of the work that's been done in feed forward and feedback mechanisms really helps to illuminate this idea. The information or the study that was done was primarily focusing on large movements and small movements. And they used a joystick in order to complete a gaming task. And they used functional MRI in order to identify what was happening in the brain. And they saw, in fact, different regions of the brain are controlling feed-forward mechanisms. And feedback mechanisms are also controlled by a select region in the brain. So, in other words, the brain areas that were active during feed-forward mechanisms were not active during feedback and vice versa. So the next sort of topic here is then what is involved in directed moving specifically? If we had to map out that motion, what would it look like? We would first see the target we desire. We would plan to use our muscles in some organized fashion. And we would be satisfied when the goal was actually met. So we received the food, it went into our mouth. And in order to make that, maybe we're using a fork, in order to allow us to use a spoon or to pick up a cup or to finger feed, we need to practice with different kinds of stimuli, and in this case, different kinds of food. So if we focus on the steps 1, 2, 3, and 4, let's think about a little bit more about what that tells us. Well, when we see the target, we're interpreting the site, we're interpreting the spatial concepts, we're informing our system about how close we are or how accurate we are to completing that particular task. We're activating multiple brain areas that we've already talked about. And we are enhancing the area of our brain that's responsible for reward and pleasure. And then finally, through the practice, we are allowing our brain to keep rehearsing and perfecting a particular movement pattern so that we can store it and call it up later when we need the same movement pattern for a different function. So in other words, if I reach for a spoon or I reach for a fork, that's going to be done in a very similar way as opposed to reaching for a cup where my hand patterning is going to look a little bit different and my arm motion reaching for the cup will be in a slightly different position so that I can be successful and not spill the liquid in the cup. So practice is essential. Practice is essential to allow our cells to wire together. Practice is essential because we need to learn from trial and error, which allows us to focus on feed forward and feedback working together. But practice doesn't mean that we should be doing a repetitive, non-meaningful task. It has to be varied. It has to be a task or a skill that will allow us to move past maybe just using a fork and a spoon, and now we can pick up a utensil or a toy or something else. We have to generalize that task. And we have to, in the process of practice, we have to activate multiple brain areas. And that is the only way for us to make sure that we are producing movement patterns that are going to be able to be used in multiple situations. And when we practice, we enrich our brain by increasing the protein levels of BDNF, which we already know are lowered in or misregulated in Rett syndrome. The BDNF allows us to make new connections of the brain in the brain, and that's really important, and it's associated with enrichment as compared to simply forcing somebody to do exercise, which may just increase blood flow to an area, which is important as well. But if you actually look at physical activity versus enrichment, it's been shown numerous times that enrichment is the way to instill better movement patterns and maintain those movement patterns. So that leads us into this idea of enrichment. Enrichment should be multisensory. It should be varied. It should be meaningful and motivating to the person, and best if it's self-selected, and always have an end goal that's satisfying. So what are some multisensory ideas that we can throw out? You can think about what's visually stimulating to the person with Rett syndrome. You can think about what's tactily stimulating. You can think about what's auditorially stimulating. And when we think about these, I gave you some examples. Visual stimulation could be food. Many individuals with Rett syndrome are very motivated by food. Auditorily, it could be music. Tactily, it may be temperature, texture, proprioception. And one thing that I think is a way to get your child interested in an object that tactily you may not be sure if they're sensing because they don't grasp it. Try changing the temperature of that particular item. Try putting a fork in a refrigerator prior to eating. The actual temperature change will be noted in the hand, and they may be more willing to grasp it because they can feel it more powerfully. Finally, other emotions that we can consider are, other enrichments that we can consider are emotion, taste, and smell. So think about whether this is something that pertains to the person that you know with Rett syndrome. So I'm going to focus first on the music. This is really interesting, I think. If you think about music, one of the things, if it's a beat that you really like, you may start tapping your foot. You may start bopping around and maybe with your body, nodding your head, just keeping to the beat. And when you're doing that, what the research shows is that we are actually activating the entire right cortex, the right side, the right hemisphere. And we're also, because of the corpus callosum, activating the left hemisphere, getting all this body movement on both sides, which means we must be activating both the left and the right side of the brain because they control the left and right side of our bodies. And so when we are listening to the music, we might be interpreting the sound. So we're also going to be activating the left brain by doing it by simply interpretation of what we're listening to. Motivating us, the more we listen to the music, the more we're motivated to listen to more. Touch and proprioception, the more that we are listening to the music and getting into the beat and swaying with our body, the more that we're impacting our skin and our muscles and joints. And with that, we're getting better and better at dancing, at tapping, at keeping with the beat. So the cerebellum is involved with that coordination. And the internal structures of the brain are going to be involved in integrating all of this and keeping the right force of our tap of our foot, the right force of our body moving, and getting rid of any of the unwanted movements during that episode of dancing. So the studies are showing that not only does music just naturally make us want to move, it actually is improving the connections inside of the cortex. And the studies are saying that not just people that are listening to music are having increases in their brain, but it also seems that if you listen to the music and you move to the music, your brain cells connect even better. And so I was thinking about that a lot with thinking about Rett syndrome and the number of children and adults who really love music and how then it's necessary to have the brain activated and mingling with all other parts of the brain, and how that increases the activity also down into the deeper structures of the brain and allows us to make global connections throughout the brain. So does it matter if you like the music that you're playing? And yes, it does matter. It seems like in patients that have Alzheimer's, as well as typically developing people, that activation of the brain occurs best and synapses or connections occur best when you are selecting the music that you like and listening to what's meaningful to you rather than just music in general. And what that seems to be doing, for example, in Alzheimer's patients, is it seems to be activating the right, the areas of the brain that aren't affected by Alzheimer's. And when those areas become more active and they weren't being used and now they become more active, it seems that they are helping other areas of the brain to function as well. It's a small study, but it's a start at what music might be doing to help a brain that is not functioning typically. And I've described already to you that the corpus callosum is the connection between the two sides of the brain. And so that's the area that's really helping us to allow the right side, which is listening to the music, to activate the left side as well. So if we consider music as a big motivator in Rett syndrome, we have to think about how that may be potentially jump-starting motion. And if it's jump-starting motion, how is it doing that? Well, one of the ways that it may be doing that is it's activating a region in the brainstem that has the ability to project quickly to multiple areas of the cortex. And in doing so, it can also activate multiple areas of the cortex within one hemisphere, and then the corpus callosum can take it to the other hemisphere. So you get this global activation. So our thoughts and our desires to move are going to depend on cortical processing, so all this higher level learning, but it's also going to depend on these lower structures that will help to activate the entire cortex. So if you focus on Rett syndrome, we know that the person is not paralyzed, but we also know that they don't move the way we would expect them to move, and we need to help them. And because they're not initiating or planning the movement and they're not separating their hands, maybe we can use music to be the motivator to try to get them to separate their hand and then work towards maybe reaching for a cookie or another item that is especially motivating for them. And that leads me to some of the studies that are being done, both preclinical and clinical studies that are being done that show that not only music increases BDNF and allows us to make new connections, but it also, in addition to the music, we also know that other areas of enrichment, such as touch or sensory integration of our vestibular system moving around on swings, etc., can also increase BDNF. And so we need to think that music is just one form of enrichment to increase proteins that are necessary for synaptogenesis. But we also need to focus on the fact that while individuals with Rett syndrome love music, they also love other aspects of life. And they love to watch people, and they love to have their favorite show or their favorite friend or whatever it may be. There are other motivators. And we need to incorporate all of that to create the best movement for them and the best motivators for that movement. So at critical time points, when we need BDNF for learning, it seems to not be there in Rett syndrome. And so that's the reason behind the enrichment, is we need to jumpstart that BDNF, jumpstart the proteins that are necessary for synaptic connections to allow for individuals to move. And an example of this is if a phone is ringing and there's not enough BDNF to allow somebody or to allow for somebody to answer the phone, somebody doesn't have the ability to move to answer the phone, then the phone may eventually just stop ringing. No one answered it and it's done. No one was able to reach out to get it. Another way of thinking about it is pretend that the message that needed to be given out just simply couldn't be received because the environment to answer the phone wasn't selective enough. So what I mean by that is the phone is ringing, there's not enough activity going on, and so the phone never gets answered and no message gets through. If you restore the BDNF, the phone will ring and someone can reach and answer it. So the idea is if nothing is around to answer the phone, then we need to do something about that because the message that needs to get through is important. We need to figure out a way to get you to answer the phone. And the way to do that is to increase the proteins that allow for the response to occur. So what is important about BDNF? Well, it's important for neuronal differentiation, which means to make different cells become either the visual cells or the hearing cells in the brain. It's important for pathfinding, it's important for survival, and it's important for connections, which is the neuronal plasticity. If you see cells connect with each other and talk to each other throughout time, multiple communications through practice, then they will begin to they will stay wired together. And we will have a feedback mechanism that goes on that allows these permanent connections to be made. And we have to have the just right levels of BDNF. We can't have too much, we can't have too little, and we can't have too much, too little. We have to have just the right amount. And how do we naturally do that? Well, we naturally do that by playing on a playground as a child. Any other form of enriching environment as we get older. Music, as I described already, was one of those forms. In Rett syndrome, all of these environments can include multisensory activities that are motivating and meaningful, that play to the person's interest and strength, and stimulate the right and the left side of the brain. And it may be that the children with or individuals with Rett syndrome have a stronger predominance for their right brain than their left. And that's been noted in a study that looked at left and right-handedness in people and showed that the typical population, 90% of us, are right-handed. But in Rett syndrome, about 40% or 41% of the individuals are right-handed, while 33 compared to 10% of the typical population are left-handed. And more, 25, almost a quarter of the population of Rett syndrome, 25%, I'm sorry, of the patients looked at with Rett syndrome compared to 1% of the typical population appear to be almost ambidextrous. So what that's saying is we've got over 50% of the individuals with Rett syndrome that may not be right-handed. And so we have to really focus on what that may mean in terms of what side of their brain might be one that we can tap into more, which it appears to be, it could be the right brain with all the music that they're interested in. But most importantly, when we think about the enrichment, what we have to focus on is that when we train a person to do any task, we need to make sure that training isn't just one activity over and over and over again. And there have been multiple studies that have been done. Early on studies looked at training cats, and whether if you train a cat who's been spinal cord injured to stand, they'll learn to stand but not walk or step, and vice versa. And there's lots of research that looks at splintered skills, which means I can put a peg in a pegboard, but that's all I can do because I've practiced that a gazillion times and I can't do anything else. So what I want to do instead is to vary the training. I want to prevent boredom. I want to prevent sleep. I want the environment to be continuously changing and stimulating to me. So how do I train and practice in various environments? Well, I can take that idea of this pegboard, and instead of just doing a pegboard all the time, maybe I play Connect 4, or maybe I pick up something from a tray. I pick up food if I'm working on self-feeding. And if I can't do these activities, but I can do feeding, maybe I alter the shapes and the textures and the size of the food that I go for. Maybe I use a fork sometimes and I do finger feed other times. Those are all different forms of training and practice, and they vary. They allow us to vary the environment. Maybe I'm going to pick up a hard crunchy cookie or a soft donut, or maybe I'm going to pick up something that's hot or something, I'm sorry, that's warm, or something that's cold. And the temperature change will also be the varied environment. In therapy, you often see varied sensory integration environments where there may be swings and mats and climbing equipment and trampolines. And we have conducted in my lab and others have conducted experiments with animals looking at varied environments also, in order to see how animals will respond to varied environments in order to either enhance their current motor control or develop something that they haven't been able to achieve in the past. And again, this depends upon the sensory input coming up and activating these central regions of the brainstem, which have a great activation simultaneously on multiple areas of the cortex. So some early studies that I did in spinal cord injury were studies that looked at varied environments, so straw and sunflower seeds and molasses to walk through. And I had animals that were either injured in their spinal cord and received these varied environments, or had a spinal cord injury and did not. And the animals just quickly that did receive the enriched environment looked very similar to normals in the way, here's a normal rat trying to reach for a pellet in a series of shelving, and he's able to reach for it and then pull back and eat it without losing balance. We saw after animals were spinal cord injured that they were unable to follow this pattern, and instead of using their hands, as you can see down here, their forepaws are just sitting on the shelf. Instead of using their forepaw, they're using their tongue to reach for the pellet, and they are unable to. They try to pull the pellet out of the shelving, and try to move up to back onto their haunches, and they fall forward every time and end up having to eat it on the floor. As opposed to the animals that were exposed to the enriched experiences, these animals were able to successfully, and similar to the patterning that normal animals used, successfully reach for a pellet, and they are able to stay back. They fall forward sometimes a little bit, but basically stay back and eat the pellet without having to use the floor to help. So when we finished that study, we were interested in seeing how the Rett model might work with the same idea. And we found that if we placed animals that had Rett syndrome, that were genetically engineered to have Rett syndrome, if we placed these animals into multiple sensory environments, and we rotated them, and we rotated the environment so they were facing different environments, different times during the day, and we moved toys around so that it was always something that was new and exciting for them, we found, let me actually show you really quickly. Here's one of the environments that we use, which gives some vestibular input, and it gives some precise placement of the limbs. So we're really working on different tasks. What we found was that the animals that had Rett syndrome, that saw the enriched environment, and the animals that had Rett syndrome and didn't see the enriched environment all had some sort of a tremor. And that tremor is shown in this pink area here, compared to the tremor of a normal animal. So everybody has a normal level, some subtle level of movement if we try to hold our arms or our legs still. And that's what this green area is showing. But much higher, we see it in the animals that have Rett syndrome. But interestingly enough, what we found in the study that was published in 2013 is that the animals gained the ability, the animals that were in the enriched environment gained the ability to step precisely on our stepping ladder. And while I'm not going to go through the details of this graph, I'm going to just ask you to look at the green area. And the green area shows that the animals that were in this enriched group performed better than all the other animals. The lower score you get, the better it is that you perform, meaning that you made the least number of mistakes. Where you see that the animals pop up right here and sort of blend in with some of the other groups, what you're seeing is that here's where we withdrew the enrichment. So they received enrichment all this time, and then we withdrew the enrichment for a couple of months, and then we gave the enrichment back. And when we expose the animals to enrichment again, you see that their ability to recognize where their limbs were in space in order to perform this precise action was restored. And we saw the same thing with the gripping task that we did, where gripping was maintained. If you look at, again, the green line, maintained fairly well across the way. The blue is the normal animals. So if you see the green was maintained pretty much the whole way, the red lines, represent the animals that were not exposed to the enrichment. And you see that they were not able to grip this grid that we had where the animals hung upside down on this grid. And the fact that they weren't able to suggests that the enrichment must have been effective in helping the animals learn to grasp. And again, as you saw up here, the green lines representing the enriched animals, those dropped during the period of time where we withdrew the enrichment. And when we restored the enrichment, you see that their scores or their ability to grip was restored as well. So this suggests that enrichment may need to be ongoing, but how much and how often we need to give it still needs to be determined. I'm going to skip through that one because that's more of the same kind of information, and we're just about out of time. What I wanted to just show you is activity-based therapies are also important, and there have been a lot of research looking at how we can use treadmills and how we can stabilize one side of the body to encourage the use of another side, as well as using sensory integration therapies, which allow us to get multiple sensory stimulations and allow children and adults to self-select which activities they want to participate in. We've conducted a few studies that look at hippotherapy and also virtual reality gaming. And our hippotherapy studies, as well as our sensory integrative studies, our sensory modulation studies looking at multiple sensory stimulations have all shown that we can improve sensory processing for the girls. They have a better sense of where proprioception is, where their body is in space. And that allows us to help them to improve their whole body postural skills and improve their arm and hand use for goal-directed movements. And so this was just a study that we did that has not been published yet on a single subject looking at some of these multiple sensory modalities. And we evaluated their abilities their ability to hold their trunk and their head while they were using their arms. And what we did was look for a test, was watched how many times the girl could touch a switch that controlled a battery operated toy. And she was very engaged and very motivated to perform this activity. And the bottom line was that new connections must have been forming because she learned to reach for the switch in order to operate the toy, and she decreased hand mouthing in the process. Similarly, in a hippotherapy study, we found that the children that were involved were able to, after hippotherapy sessions, were able to climb a series of steps with less assistance from another individual for postural support. And finally, for the current study that we're working on is virtual reality gaming, which we're still enrolling for. And so if you're interested, please send me an email and let me know that this is something that you would like to learn more about. It's a study where we're looking at how gaming or the use of activities on the computer can encourage the individual with Rett syndrome to separate their hands, to stop hand mouthing in order to reach and use their arms to activate whatever is happening on the computer. So we've taken away the idea of having to hold a joystick or having to hold some sort of gaming device. And we have a software program that allows the children or the adult or the teenager, it's a lifespan study, to be able to separate their hands. And at first, a little bit of separation allows the activity on the computer to work. And then as the child and the individual begins to practice more and more, we expect greater and greater amounts of separation or longer periods of time that they're not hand mouthing in order for the activity on the screen to continue. They get to select which activities so that it becomes very much motivating for them. And the sessions are all run inside the homes with us, either through therapy, telehealth, or by being present in the home with you, training initially, checking up, advancing the skill, advancing the activities by working with you and the individual with Rett syndrome to make sure that we keep active, keep the activity that we're using on the computer something that's the most motivating for them, and can constantly be changing them so that we keep the idea of novel selection of activity to continue to activate various regions of the brain. So if this is something that's of interest, I'm happy to talk individually to others about it. And I believe that the poster that you see or the flyer that you see here is posted on the Rett syndrome website. The exciting part is that carryover outside of the sessions has been seen, and we're seeing these in multiple different environments for carryover. So I'll leave you with these takeaway concepts that in purple is sort of the bold areas that are in purple font are the main ideas that we need to make sure that we use motivating, enriching environments with lots of training and practice, using new ideas, new activities, new music, whatever it is that you choose, constantly changing things up so that the brain doesn't become bored and the person with Rett syndrome doesn't start falling asleep while you're hoping that you can engage them and increase their movement patterns. So with that, I will end and see if you all have any questions for me.
Great. Thank you, Pam. I was on mute there. Okay. Wonderful, wonderful presentation. Thank you so much. We have number of questions that were pre-submitted. I think you addressed a lot of them in your presentation, but let's revisit them because they may be questions that are on other people's minds, and we have some that came in the queue. So if we can, let's leave your slides up on the screen, so if you need to bump back to a previous slide, we can easily do that. Okay? Great. And thank you for doing such a good job on your timing. You are definitely a professional professor. Okay. One of the questions that came in, and you saw this ahead of time, was about those with epilepsy and with seizures. And they're wondering if prolonged, repeated seizure activity over a lifespan has an effect on learning skills.
I think that in part has to do with how often the seizures are occurring. If a person is not able to focus in on their environment and not able to have the opportunities to engage in multisensory activities because they're seizing a lot, they're having multiple seizures, then yes, that will have an effect. If they're well medicated and they are not having seizures that cause them to really be shut out from their environment for a good percentage of their waking hours, then they have every ability to learn and to be exposed to all of the ideas that I had suggested. The one caveat would be that you have to be careful with some children and adults with seizure activity in terms of the types of sensory stimulation that you provide. For example, if you provide something that maybe is on a screen that changes lights a lot, sort of a strobing effect, there has been some research that shows that sometimes a strobing effect can increase seizure activity. So you just have to be careful, and you can discuss that with your physician about what might heighten seizure activity. But as far as just generally, while the person is not having seizure activity, they should be able to engage in all of these activities, and that actually should be helpful for them to be able to activate a lot of different areas of their brain and trying to get connections made so that they can be much more functional during their waking hours.
Great, thank you. Yeah, that's great advice. And as a mom with a child with intractable epilepsy, I can relate to everything that you said. And I want to share for us personally that we respect when Katie is down having seizures, but we also have seen that once her seizure clusters pass, she really comes right back to her previous abilities. We have not seen a degradation of skills due to that. And I know a lot of parents fear that. So thank you for that encouraging information, to be respectful and talk to your individual physician for their thoughts, especially an epileptologist. If you're not currently seeing one, there are neurologists who specialize in epilepsy. And if that's a problem with your child, make sure that she is being seen by an epileptologist, okay? All right, the next question in the queue is, my daughter can't keep her eyes focused. She keeps rolling them up, and how can I get her to focus on anything? And I think we see that a lot with a lot of the girls with Rett syndrome, where they kind of look away, and it appears that they're not focused on what the visual activity is right in front of them. What are your thoughts about that?
Well, so I agree with that. Sometimes I feel that the girls and women with Rett syndrome are really looking at the world through peripheral vision, and it's almost their way to shut some things out, is sort of my impression of it sometimes, and be able to, still appreciate the world without actually visually focusing on it. I also feel sometimes that the girls and women spend an awful lot of time, because their eyes are what works so well for them, that they are staring at things and looking at a wide variety of items throughout their day, and it's almost a break if they can just use the periphery sometimes. But as far as the idea of the eyes rolling up and moving around, there are a wide variety of techniques, and it's hard to just give you a blanket answer without knowing your particular child. But some of the ideas that you can try are putting on a visor Sometimes it's simply the light, and you just dimming the light will help. Sometimes using a dimmer room or playing with your daughter in a dimmer room. Sometimes it's just even putting your hands, cupping them sort of around their eyes and seeing if you can help them to narrow in and focus and guide them to where you want them to be. But without seeing your daughter or being able, your therapist may be a better person to ask, or a person who may be able to try to apply some of the different therapies that can be done, like I stated, of trying to narrow in on the visual field a little bit and put somebody in a dimmer environment. Use initially less bright colors or more or brighter colors to see what it is that they'll focus more on. So trying to find what motivates them. So it's a trial and error approach.
Great. Okay, thank you very much. Next question is from the parent of an adult, and they're asking if a lot of the information that you were suggesting is relevant, helpful for the adult brain who has been living with Rett syndrome for decades. A lot of the research seems to be focused on younger children and the impact of the enriched environment. What's your experience or thoughts for our adults? And
okay, so it's actually perfect, because if you look at my takeaway concepts down here, it says enrich throughout the lifespan. And that's what's really important. The aging studies, which I didn't have time to show you about today, really show that even in throughout the lifespan, and also in aging, where we see naturally degeneration in the nervous system, or natural decline, I should say, of the nervous system, we can still enrich the experiences and activate brain regions, and we can still get new learning. So I apologize. Our nail just the enrichment can occur throughout the lifespan in different ways. So you just have to approach what is best and motivating for that individual at 20, at 30, at 40, whatever the age is. But it absolutely should be used and can be used throughout the lifespan with the same ideas. Everything that I described, you need to find out what's motivating. Some of the issues that relate to aging, for example, are changes in vision as we move from a lit environment inside the house out to outside, where it might either be bright, where it could even be more brightly lit, and the eyes just have to focus, have to change and adjust. Same as if you're coming in from a brightly lit outside and coming into the dimmer lit. If you're coming from the sunlight and coming into your home, it's dimly lit. You also could fall because, as an aging person, because you're not able to adjust your eyes quick enough to the changes in the light. And so we've got visual issues that happen. But if we can continue to function and allow the brain to be activated, there are multiple other areas of the aging nervous system that can be changed. We can provide sunglasses and that sort of thing for the eyes, but for the rest of the nervous system, we actually can use enriching experiences to improve postural control, to improve grasping and reaching and strength, etc. So absolutely, enriching environments work throughout the lifespan.
thank you. That is incredibly encouraging news, and I hope everyone heard that loud and clear. Based on some of the things you just said and the previous question about girls looking away and the boys looking away, I want to point out that there are some researchers currently looking at whether there is some level of cortical visual impairment in Rett syndrome, and they hope to be able to be presenting to us in December. So we have it in our RettEd calendar for December. If their research is ready to publish and share, and we invite everyone to come back in December, and if they're not ready, we'll reschedule. Things are a little off this year. We really look forward to hearing more about that. And we can thank the work of the collaboration with our related disorders, because we know that is an issue with CDKL5 deficiency, and many of our researchers are working with both populations. So it's a good indication of how we are not siloed in Rett syndrome, and we have to look at other disorders as well. Okay, next question, Pam, is can you explain why there's often a sudden change in spatial awareness and visual perception during the regression phase in Rett syndrome, and why sometimes that seems to recover? If you have any insight into that phenomenon of the regression period and recovery.
I'm sorry, can you repeat the beginning of that question one more time? I apologize.
Sure. Okay, so the parent is asking, can you explain why there's often a sudden change in spatial awareness and visual perception during the regression period in Rett syndrome, and why they seem to recover some of that ability post-regression? And she describes a little bit about what's going on with her daughter, but you'll have to excuse me, I have to get close because my eyes are so poor at this stage of my life. She says that her daughter, around the ages of 4 years old, couldn't grasp a rail and would put her hand between the rails instead, or would become very distressed if the floor appearance changed. For example, going from carpet to wood or grass to gravel, as though she couldn't make sense of it. But now at the age of 10, she seems much better. She still struggles with surface changes, but doesn't seem to be having as many issues as she did during her regression phase.
Okay.
Does that make sense?
Yeah, I think so. So I think that some of what that may be due to is a little more complicated than I can explain in a couple minutes. There's a lot of research that's looking at what happens in synapses and connections between cells in the brain and the spinal cord, and all of the other more microscopic things that are happening at the cellular level when we have a change in the connection. So in Rett syndrome, it may be, sort of a really simplistic way of looking at it, is it may be that connections are there, and that during this critical period in development, what we typically have is lots of regression. So we have cells die, we have cells stop communicating with each other. It's called withdrawal. We have a variety of different events that occur. And that occurs in everybody. And it's a fine-tuning method or remodeling method of the nervous system in order to get normal movement patterns to occur, or normal cognitive patterns, or whatever it may be, to occur. And it may be that that's happening too much in Rett syndrome. It may be that some of the activity that's going on at the synaptic level with molecules that should be present at the different sites where the connections are made may not be there, or they may be being removed more than they should be. I mean, there's a wide variety of things. It's really hard to explain it without showing you pictures. But there's a wide variety of things that can be happening on a microscopic level. Let's leave it at that. And it may be that when things, sort of the shock to the system, when things start to ease up a little bit, and some of that regression has dissipated a little bit, the nerves can begin to try to make new connections again. And so in the process of sort of having a connection, losing the connection, and then trying to restore the connection. So it's sort of like you can't find something on your computer and you keep searching for it, and all of a sudden you've got it again. And there's methods and processes that the nervous system uses to get rid of connections and restore connections. And in Rett syndrome, maybe too many of those connections are being degraded at an early time point when we don't want them to be, because of a wide variety of things that aren't happening in the nervous system. And as we get past that critical time period and we keep working on skills, eventually some of those neuronal connections get reformed. And that may be why movement patterns are naturally coming about. But it also could just be you're still working with your child. You're still providing them with some enriching experiences. Maybe they're getting therapy. So all of that is helping them to learn. And the more you learn, the more connections the nerves are making. So as the connections are made, they correlate with improved behavioral outcomes. So maybe they know where their body is in space better, so they're able to reach for an object better. They're able to grab the railing of the stairs, or they're better able to understand sensation that's coming in at their feet, so they can walk between a carpet and a floor, or grass and a sidewalk. So there's a wide variety of things that are happening in the nervous system that may be able to explain that, but that would almost be like another whole talk. I hope that that gave you some information.
Yes. And I think that if we knew the answer, we'd be a lot further along in our research with Rett syndrome in providing interventions and treatments, but that was a really wonderful answer. And I thank you for giving that parent credit for probably working with her, and that the intervention and therapy that she's been doing has probably complemented and improved what is already some, development that's going on naturally post-regression.
Absolutely.
Yeah. Okay, so we've got a couple more questions. We're getting close to our time. I want to ask, a parent has a question about coming to our COVID times and the length of time that our children are not being engaged directly with school programs, clinical therapy sessions, although we see a lot of teletherapy coming online right now, and we see a lot of schools trying to do virtual education. It's not the same as what our regular schedules have been. So in your professional opinion, do you have concern that our children will suffer regression? And are there things that we can be doing during this time at home while we're juggling so many other responsibilities to minimize the impact?
So the research, of course, we're all familiar with, I'm sure, the research that looks at why we need to do summer school for many children, why most schools send home some sort of a summer package for children to work on in order to keep their skills going. Because yes, if we don't practice, we will begin to lose skills. How quickly that occurs, that may be unique to each individual. But training and practice are essential, and the continuous practice is important. But we still don't know how much and how often. So the dosing of that training and practice is still not known. What's best is to try to continue with the routine that you have, to try to provide the stimulation that you would normally have, and then maybe, and I know it's hard, but maybe up it one or two things each day, or one or two things each week, depending on the situation that you have in your family. Instead of maybe always playing with the particular toy, change the toy. We have the ability to do all this online ordering. Maybe go find another toy or another game or another activity, whatever that may be, that your daughter really enjoys, and change it up a little bit. Give them something novel, something new to do, which can also motivate and excite the person to play with it more or to use it more. And maybe it's food. Maybe there's something really motivating and you typically don't have the time to spend on self-feeding. Well, maybe this is the time. Spend a little bit longer on feeding and self-feeding and working on those kinds of skills, so that you can then encourage your daughter to say they're reaching for a cup, and say, well, remember how when you reached for the cup, now I want you to try to think about that and reach for this toy in the same way, so that you are trying to increase the number of times that they move, and also increase the repertoire of when they can move and how they move. So I do think it's essential to keep going. I know it's hard on families right now because you're trying to be everything to your child. But if we don't continue to add the practice, the skills can be not lost, but certainly degraded. And as I showed you in one of the animal studies that I have, I'll try to come back to it. I showed you that when we provide continuous activity, this particular mouse, as an example, maintained better skills, didn't make mistakes. And then when we took away the activity, they made mistakes again, similar to what animals that weren't receiving enriched experiences did. And when we restored the practice, or the environment, I'm sorry, the enriched environment, we were able to restore their ability to walk across this ladder without making mistakes. And we saw that in multiple activities that we did, multiple tests that we did. So I think that don't also fear that should I not be able to provide as much practice and training as I want to during this time, that my child is doomed, because it also shows that if you can just restore or provide that practice again, the skills will come back. It may take a little bit longer. The learning curve may be a little bit steeper, but they will return.
Thank you. And as a parent, I want to follow up and, and support what Pam is saying, that there's a lot of things we can be doing in our home. And next week we have a series of talks around communication, and we're going to give some ideas of how siblings and other people in the home can be doing some of this activity with your child as well, so you don't necessarily take all of the burden on yourself. So I'll share a slide in a minute that will give the dates and times that you can tune in for that complimentary information that's coming. You touched on something about holding a cup, and a parent did ask a question. If you have any advice on what to do for her daughter who can pick up a cup and hold it, but then when she releases it, she flings it away and throws it. Real quick, do you have any practical tips on what they could do, maybe with something that they have around the house, to help her work on that skill to hold a cup or not throw it when she releases it?
So it depends on whether it's truly throwing or it just looks like it's throwing. So if it's truly throwing, then that's behavioral, that can be discussed with, behavioral psychologists can help you with planning how to rid a behavior that you don't want. If it's really just that the release is happening too quickly, that's motor, that's the brain. That's the motor, one of the motor areas of the brain that I talked about, called the basal ganglia, is very much involved with allowing us to only have the movements that we want and get rid of all the competing movements or the unnecessary, unwanted movements. And very early on, if you think about a child learning how to, for example, stack 1-inch blocks or little blocks to build a tower, that initially they can barely stack 2 because every time they release it falls over. And that's because they haven't developed the refined grasping and release skills yet for motor control. As they get older, they can much more, you watch the difference. They come at the target quickly, and then they gradually and slowly lower the block onto the block that's already there, and then slowly take their fingers away to release. And the blocks don't fall over, then they can build a tower. So that happens over time in normal development. With girls with Rett syndrome, we see sometimes that the reach and the grasp are not graded, not done in a sequence that would allow you to have a more refined grasp or a more refined release of an object. And so that would be something that could be trained. So this question depends on whether the throwing of the cup is truly throwing a behavioral pattern, or whether it's just that the fingers come away from the cup much too quickly and in a whole group, a whole unit, as opposed to individually pulling away gradually, and then the cup looks like it's flying across the table. Does that make sense?
I think so, very much. I mean, we'll know if the parent writes in some more questions or for further comment. We are getting to the end of our hour, and I know that we all only have so much tolerance to be in front of the screen. So I want to ask real quick, give you a chance to answer some questions about your research study that you presented. And a parent asked if this study is being conducted in the US only, or if you're accepting people that are interested outside of the US.
So currently it's United States only. However, we are working hard on developing some sort of we're trying to work on a telemedicine, teletherapy type of a technique in order to allow us to come into the homes of people outside of the United States. We are excited about where this is going. We have a lot of great ideas. We have applied for funding to support this. Right now, unfortunately, with the way the world is, a lot of the funding is just all delayed. And we just don't know what's happening with some of it. I have international collaborators for this project. So we are working in multiple ways to try to make this happen. But we're not giving up just because we don't have funding. We're still considering and looking and trying to figure it out. We are sticking in the United States initially where we're able to get to the homes where the project will be run, but we'll also be able to use our teletherapy type of techniques and try them out and see if it works. And because we can be in the home and we can be using a screen to zoom into the home, we're able to see which one will work better and figure out where the difficulties are with just the screen ideas. The other aspect to it is certain equipment needs to be had. Everybody that's doing the project needs to have certain equipment. And we are trying to figure out how we would get some of that equipment, if it's not available in other countries, how we would get it to people in a cost-effective way. So we're hoping, and stay in touch, send me your information. And as we begin to be able to open up to outside the United States, we will be in touch.
Great. And we'll absolutely announce that and share that information when that time comes. And I know many are eager to help participate in your research. So thank you so much for this information. Last question for you, and then we're going to go into some closing comments and let people get back to their unusually scheduled activities. If families have any virtual gaming devices in their homes right now and want to start practice while they're at home, are there any contraindications that you're seeing other than potential seizures and epilepsy to be aware of? And would you encourage families to perhaps try and start some of this on their own, maybe using a virtual reality goggles as to give incentive walking down the hall, things like that? Are you recommending that people do this on their own right now, or do you want them to wait until you?
I do not recommend them doing it on their own. Especially not with the goggles. I feel that with Rett syndrome, part of how the girls communicate is with their eyes, and covering them up could be disastrous. You won't know if they need the goggle to be removed. You won't know anything, and I'm not even sure that most of the girls would allow you to keep the virtual reality goggles on their eyes anyway. So we're not using that. That's not what I meant by our technique. Our technique is activity-based, using the computer, gaming. And we have developed our own software in order to allow us to do what we're doing. So without that software, people can't do this anyway. But as far as the ideas behind it, the idea of enrichment, the idea of finding things that satisfy your daughter, that motivate the person you know that has Rett syndrome, those ideas and concepts can be used. But I can't, until we have completed this work, analyzed it, and published it, I cannot advocate for it because I can't identify the exact results at this point. So no, I would not encourage people to try to do what we're doing in our study and in your home environment. If you would like to participate in the study, we'd be happy to have you enroll, and we could get that going once we're allowed to start working with subjects again. Right now, there is no one is allowed to do clinical research and start doing new enrollments for at least another month. And so right now, most projects are on hold.
Okay, thank you very much. That is really good words of advice, and I appreciate that. And I shared in the chat field a link to our website where you can find the flyer for Dr. Diener's research study. And I know that she will be happy to take interest, and we'll get back to folks when she's able to begin enrollment again. So I'm going to start closing now, and I want to close with a comment that a parent made in the chat field, Pam, because I think this really summarizes how we're all feeling. And she said that this is the best presentation on OT she's ever seen. She had given up at the end of her daughter's schooling on working on OT because she felt that was a pointless exercise and there wasn't a lot to do. And obviously her daughter is an adult now. But she's going to consider adding it back in to their program now that she's heard your information. And I think that's probably the best compliment you could receive as an outcome from your presentation today.
Thank you. I think that I'm hoping that this presentation did just that, is it helped to empower people to know and have a better understanding of what is needed. And then you can look around your own homes and your own environments and figure out what it is that you can stimulate and excite your daughter with. Even just watching the wind sometimes outside and then talking about that and having conversations and incorporating that into your, whatever the activity is that you may do, so that you can broaden somebody's interest. Maybe they don't naturally have an interest in a particular activity, but that doesn't mean that they never will. Sometimes they just don't know enough about it. So I'm hoping that you also will recognize that when I say multisensory and motivating, start with motivating, increase the sensory stimulation, and maybe you'll introduce your daughter to something that they never knew was there, and they will then develop new interests and new motivating activities. So thank you for your time.
Well, thank you. Thank you for your time. We know that you are busier than ever trying to figure out how to continue your work in a virtual environment. And we really appreciate that you kept this date and that you were with us today. So thank you very much. I'm going to take the screen back over now. If you don't mind, you're welcome to stay with us, please. And
how do I?
There you go.
I'm trying to see, how do I send it back to you? Do I send it back?
Nope, I've got it.
Okay.
I think, do you see my slide? I think, do you see my slide?
I see yours.
Brett's in your, okay, good. Technology's working. We're all working things out now. Okay, so we really just appreciate your time and your commitment to our families and our shared work to put the dreams. I mean, we all have dreams for our children, and you've given us some really practical information to put it into a plan of action. So thank you again. And to our attendees, all of our families and the clinicians and professionals who joined us today, we hope you found value in today's session and that the knowledge you learned will empower you in ways great and small that you can put into practice now, that you will share this information with the professionals who do work with your children and use this time to maybe develop a plan to modify your goals and modify your programs for when we do get back to school and we do get back to our day programs and we do start getting out of the house, and that you've heard, don't be discouraged, try some different things while you're at home and give us some feedback. We request now, especially to families, that you try your best to understand how to continue advocating for your children. Remain optimistic, try to replenish yourselves in your lives. Their success depends on you, and we know that if we believe in them, we will all be part of something very special. So we appreciate it, and we appreciate you. We hope to see you here with us next week on Monday, April 27th. We will have a Facebook Live where Dr. Teresa Bartolotta and Jill Townend are going to continue taking us through some valuable information that is in their recently published Rett syndrome communication guidelines. On April 30th, we will be back again, Facebook Live with Dr. Mary Lotan, physical therapist. And on May 4th, Dr. Bartolotta and Dr. Townend are going to be back with us again to take us through yet another chapter. This is really important stuff. Dr. Lotan in particular would like to use his time with us on April 30th to answer questions. So we have a Survey Monkey that's live. You can find it on our Facebook page, or if you can copy this link down, do me a favor and go back and watch his recordings. They're up on our YouTube channel. They're in our Facebook feed. They're on our website, rettsyndrome.org, the COVID-19 link, and watch those sessions. A lot of what we're presenting across physical therapy, from what Dr. Diener talked about today, what Teresa and Jill Bartolotta are discussing, are all interrelated. We want you to watch these recordings when you have some time. Think about it. Submit your questions for Dr. Lotan, and he'll use his time on the 30th to do QA. And I know that Pam, Teresa, Jill also would welcome the opportunity to answer any questions that come up after you watch these recordings, access their materials. The communication guidelines book, because I think there we go. I think that just went there. I think should be back now. We accelerated its availability. It is orderable. It is for purchase. You can order a print version. Shipping is taking a lot longer these days. You can also purchase an electronic download version, and that's particularly helpful maybe for our families outside of the US. Okay, so we are going to continue to bring you information. Right now, most of our events are going to be online, and trust that we will be together again for in-person events when we get the message that it's the time for us to safely do so. But in the meantime, we hope that these live sessions are keeping our social connections while we're having to be physically distanced, and for you to get a sense that you are not alone in this, and that rettsyndrome.org is committed to you and to your children, and we're here for you. So finally, we believe that all of this information should be available to you for free at no charge, and you can make yourselves available to access it. And we are able to do that, and thanks to our sponsors through Acadia Pharmaceuticals, Greenwich Biosciences, and Neuron Pharmaceuticals, particularly in our economic environment right now. We're so grateful for their support. So we thank them. Okay, so thank you for being with us. And, you know, our children are worth every effort to overcome the challenges before them. So we have a lot of challenges. They have a lot of challenges. I think that one of the strengths we have as a community is that we train for this. We train for the marathon, and we can get through this. So until we can be together again next week, be well, stay healthy, wash your hands, know that we care deeply, and we're going to go ahead and conclude the webinar for now, and we'll see you again next week. Thanks for your time.